Dear colleagues, this is a case of cataract surgery in a patient with radial keratotomies. As you can see, there are a lot of archaic cuts, and I prefer to do a scleral tunnel about a millimeter and a half or so in order to stay away from those cuts. I did the first eye and made incisions close to the limbus, and because of the numbers of these radial cuts, there were so many. Even though I placed the incision in between them, I still end up with having to suture one. So I decided in a second eye to go for a scleral tunnel. Incisions, it's a little bit trickier to get inside the eye, but you can get used to it. Place some adrenaline to have a larger pupil, and using the 25 gauge forceps I'm able to get through this scleral tunnel inside the anterior chamber and start doing the capsulorhexis. I'm aiming for a larger one, 5.5 millimeters or so. This is a myopic patient, but as you will see, the cataract, it's a little bit stickier and stuck to the bag. Even though I do hydrodissection, I still getting sticky. So I open up one of the paracenteses, make the main incision. I cut the conjunctiva, so I'll have no ballooning of the conjunctiva due to regress of BSS underneath, and starting the phacoemulsification, I do a horizontal chop. The nucleus is not that hard, it's a soft sticky one, and I'm sensing loose zonules here. The bag is kind of wobbly, so I'm trying to not rotate the nucleus as far as possible inside the bag. So try to keep the phacoemulsification in the bag and without rotating the nucleus. So I'm getting with the chopper inside the bag and do some more lateral chops, bringing the pieces forward towards the phacoemulsification needle, and slowly I'm able to take small bits and pieces of this half of the nucleus, and then slowly making more room inside the bag. I'm able to move the pieces and take it out one by one, little slices and small pizzas. Notice the fact that the anterior fluctuations are pretty high. The vacuum, it's a little bit higher than should be in this case, but half of the nucleus I'm able to aspirate it pretty steadily, and I'm getting to the other half. As you can see, even though it's not hydrodissection done in the perfect way, you can still be able to take out the nucleus and epinucleus after this bag and finish the phacoemulsification. So in these loose zonules we can practice phacoemulsification without rotating the nucleus, and will help the post-op recovery, will help to keep the integrity of the zonules, and will be a better stability in long term, the bag and the IOL inside the bag. Due to this many RK cuts, we're not able to calculate the IOL power exactly, so we have to manage the patient expectations post-op, and I'm usually keeping the refraction a little bit too close to -1 to be able to manage any refractive surprises. Placing AC maintainer, and with aspiration needle I'm able to finish cortical removal, and then implanting under irrigation single piece IOL. Notice the fact that this approach to the scleral tunnelizing the incision 1.5 millimeters will keep the arcades intact, so there's no need for suturing at the end of the surgery. Washing out the viscoelastic, placing myocoltocaustic the pupil and an air bubble, and at the end subconj injection of antibiotic and anti-inflammatory agent. Thank you for your attention.